In this lecture, we'll be talking about the meninges and cerebrospinal fluid. Now, from our lab, we've already taken a quick look here at the dura, and you've seen the arachnoid, but let's go into a little more detail here. First of all, if we peel away the arachnoid, when we're looking, and we can touch right on a gyrus here, and you can put your finger into a sulcus, the pia is what is tightly adherent to all of the gyri. You'd really have to peel to try to get that off. Importantly, blood vessels are on the pia layer. Okay, so we have a space in between the pia and this arachnoid, and this is called the subarachnoid space. That's very clinically important. We'll talk about later. And then the arachnoid layer we can see extends across all of the sulci and all of the depressions. Right, so I just mentioned that the pial layer is vascular, so we can just imagine if a blood vessel ruptures here, where is the blood going to go? It's going to go into this space right here between the pia and the arachnoid, the subarachnoid space. So the subarachnoid space coats the entire brain and spinal cord, and we'll see there are some areas where we have a pocket of enlargement of the subarachnoid space, and those are called cisterns. So we have one called the cisterna magna, which I'll show you in just a minute, and more clinically important, the lumbar cistern, which extends below the level of the spinal cord. So if you've ever seen someone have a lumbar puncture, you put a needle in the low back and you draw cerebral spinal fluid out. Well, you're putting the needle in the lumbar cistern to get that cerebral spinal fluid. Okay, so just an older drawing here showing you the pia, again tightly adherent to the brain, and then the arachnoid, and then we have the outer dura. So coming back to the subarachnoid space, I mentioned that if a blood vessel sitting on the pia ruptures, it's going to go into the subarachnoid space, and that is known as a subarachnoid hemorrhage. So here, if you can appreciate right where my yellow cursor is there's a focal enlargement of a blood vessel. Here we can see a blow-up of it. This is an aneurysm. An aneurysm is like a little balloon that is kind of blowing up under pressure here, and when that ruptures, typically the patient will have a very severe sudden onset headache with a lot of blood then that goes into the subarachnoid space. Okay, the other thing that can go wrong in the subarachnoid space is you can have an infection, and so that is called a meningitis. And so for both a meningitis and a subarachnoid hemorrhage, we'll talk later about things you can expect to see if you were to obtain a sample of the cerebral spinal fluid and count blood cells and things like that. But a couple of physical exam maneuvers that can be helpful for both of these are called the Brzezinski and Koenig sign. So here we have the Brzezinski sign down here, and in both meningitis and subarachnoid hemorrhage, flexing the neck is very painful, and that's because you stretch the meninges when you do that. And so in either of these conditions, the patient will often tell you, they just can't bend their chin down to their chest. But if you try to do this on examination, we flex the neck here, the legs will really involuntarily flex. Okay, and they're doing that to try to relieve the stretching here of the meninges caused by the neck flexion. So that is known as the Brzezinski sign. The Koenig sign is where you flex the hip and then you try to straighten here at the knee. And the patient will have extreme pain when you try to do that. And the reason is nerve roots, like the cauda equina, these exit through the subarachnoid space and they're passing through. And so when you try to extend the leg in this position, you're stretching those nerve roots, which are already inflamed by either the meningitis or the subarachnoid hemorrhage. All right, so here's just a picture of the patient when we do a lumbar puncture. It's easier if the patient's lying on their side and if the legs are flexed up like this. And we put the needle typically into the L4-5 space. And so here is the lumbar cistern. So the spinal cord usually ends around L1, L2, sometimes even T12. Okay, so anatomically, we just want to know we're putting the needle in the right place, right? You don't want to pith the spinal cord. And if you're going in at L4, L5, you're way below the end of the spinal cord. You don't have to worry about damaging the cord. Okay, so again, normally, what do we find in the subarachnoid space? Normally, cerebrospinal fluid. Okay, so between that pia and arachnoid, that's where the cerebrospinal fluid is, which cushions the brain and the spinal cord, has a protective function. Okay, things that do not belong in the subarachnoid space are blood. So again, that's an aneurysm resulting in a subarachnoid hemorrhage, or inflammatory cells, which is a meningitis. So I mentioned there are pockets of enlargement of the subarachnoid space. One is called the cisterna magna. Now you actually can put a needle in here and draw out some cerebral spinal fluid. I don't think anyone does this anymore because it's just not safe. When I was a neurology resident, believe it or not, there still was an older neurologist who would do what's called a cisternal tap, where he would put a needle in back here and draw spinal fluid out. He actually had quite a significant tremor, and I remember watching him do this on a patient. But putting the needle in the lumbar cistern is a much safer way if we need to analyze cerebral spinal fluid. Okay, so we have a peel layer, we have an arachnoid layer, and then we have the outer dura, which is very tough and very strong. And there are two layers of the dura, an outer perosteal and an inner meningeal layer. So the outer perosteal layer is attached to the skull. It contains blood vessels and nerves, which is actually really important. When these are stretched, there are nerve endings here. And so even when we talk about migraine and the pathophysiology of migraine, we'll talk about abnormal nerve connections with blood vessels in the pathophysiology of migraine. Okay? And in between these outer perosteal and inner meningeal layer, they separate in places that result in venous sinuses. So we have potential spaces that arise around the dural layer. One occurs under the dura, that's called the subdural space, and then outside the dura, between the dura and the bone, we have an epidural space. Both of these will become very important as we talk about head trauma and bleeding that occurs in the brain after head trauma. Okay, so let's just start from the brain and work out. So here we have a gyrus. So right on top of that is the pia, and notice we have blood vessels here. Okay, so this space right on top of the pia is the subarachnoid space. Okay, so on top of that we have the arachnoid, and then we have the layers of the dura. Again, an inner meningeal layer and an outer perosteal layer, which is attached to the skull. Okay, so remember there are potential spaces around the dura. So between the dura and the arachnoid, a potential space here is the subdural space. Okay, and on the outside of the dura, there's another potential space here called the epidural space. So in head trauma, the two common bleeds that we'll get around the dura are called subdural and epidural hematomas. Right? Now, the dura, we can see right here, adherent to the skull, and so the blood is underneath the dura, so this is called a subdural hematoma. Okay, and this is due to venous drainage into this space. And so here you can see a torn vein, which is causing leaking of venous blood into this space. So subdural hematomas we see most often in the elderly after a head trauma. Whereas epidural hematomas, here again in blue is the dura, okay, and now the blood is outside the dura, and so this is called an epidural hematoma. These are more common in younger individuals, because what happens is with age, the dura gets more and more tightly adherent to the skull, so we don't see epidural hematomas very often in the elderly. Another important point here is that epidural hematomas are highly associated with skull fracture. Okay, and the other point is these are arterial. So I have arterial blood going into the epidural space. Now, a couple of things just by appearance. Epidural hematomas wedge into the brain. Okay, so here we see this wedging into the brain in all three of these. So that's kind of a classic appearance of an epidural hematoma. The other significant point here, and I know we haven't done our neuroradiology lectures yet, but there are only two things that are allowed to look white or bright on a CT. One is calcium, and the other is an acute hemorrhage. And so here we see the skull all the way around, so that will always help to tell you you're looking at a head CT. And so the only other thing that can appear white here is acute hemorrhage. And so this is an epidural hemorrhage. You can see there's mass effect. We'll talk about these spaces later. These are the lateral ventricles. We don't see them on this side, and that's because of the compression effect. And also here, the red arrow, notice there's a skull fracture. Okay, so remember, epidural hematoma is highly associated with skull fracture, and this is arterial bleeding. Okay, so think of younger individuals. Liam Neeson's wife years ago went skiing, had a relatively minor fall, it sounded like, and then passed away shortly after from an epidural hematoma. Now, subdural hematoma, again, think of an older individual falling, hitting their head, and these will often evolve a little more slowly because it's venous blood. But here again, you can appreciate it's bright. So this is a new hemorrhage. Okay, and subdural hematomas, in contrast, tend to layer out along the entire surface of one hemisphere. They don't wedge into the brain like an epidural hematoma. Okay, we can also see that there is some mass effect here because later on in this lecture we're going to talk about the lateral ventricle. So here's the right lateral ventricle. We don't see it on this side, and that's because of the mass effect here of the subdural hematoma. So you need to recognize the appearance on a CT of an epidural versus a subdural hematoma. So the dura covers the entire brain and spinal cord, provides a lot of strength and stability. And there are two important infoldings that you need to know about. The falx cerebri is a reflection of the dura into the interhemispheric fissure that stabilizes the right and left hemisphere of the brain. The cerebellar tentorium is a reflection over the cerebellum that we'll see that provides an important opening for the brainstem. And clinically, we want to associate uncal herniation anatomically here with a relationship with the cerebellar tentorium. All right, so here is the cerebellar tentorium right here and over here. So again, the cerebellum lies just underneath. Okay, and here is the brainstem. And so the temporal lobe here sits right on top of the cerebellar tentorium. And so here this patient has a subdural hematoma. And what can happen in this situation, really with any mass lesion in the brain, is that the most medial part of the temporal lobe, let's identify it over here, this is the uncus. What can happen with the pressure effect is that the uncus can just get pushed right over the lip here of the cerebellar tentorium, and that can compress on the brainstem, and most often early on it will push on the third cranial nerve. So patients that have a third nerve palsy, that become unresponsive, you can assume that that patient had herniation of the uncus. So just a few pictures here from our lab that I took just recently. So here's the dura, and this is the falx cerebri, and here's the cerebellar tentorium. So imagine we're looking on the undersurface. So the cerebellum would be down here, the temporal lobe would be on the other side here of the cerebellar tentorium. Okay, another picture of the falx, cerebellar tentorium. Okay, here you can see kind of this sharp edge of the cerebellar tentorium. And again, just another close-up. Now let's talk a little bit about the cerebral ventricles, which contain cerebrospinal fluid. And so the ventricles consist of a body which makes up this portion right here. And then back here we have an atrium or a trigone. Okay, so a body, and then an atrium or a trigone back here. Okay, the other parts are named by the part of the brain that they project into. So anterior to the body here we have the frontal or anterior horn. Okay, and from the trigone, so back here it projects to the body, this goes back to the occipital lobe, so this is called the occipital horn of the lateral ventricle. And then this projects down, imagine this going down into the temporal lobe, so this is called the temporal horn of the lateral ventricle. I think this is a bit overrepresented in this drawing. This is actually relatively small compared to this part of the ventricular system. All right, so looking at it from the side, again, this is one of several C-shaped structures in the brain. So here is the whole lateral ventricular system. Okay, so this whole portion right here is the body. Then we have the atrium or the trigone back here that projects into the occipital horn and down into the temporal horn. And then this portion right here is the frontal or the anterior horn of the lateral ventricle. So there's a right and a left lateral ventricle. They each have an outlet chamber right here, the interventricular foramen of Monro. Okay, so both the right and the left ventricles project cerebral spinal fluid into this space right here, which is the third ventricle. Kind of has a shape of a bird's head. Okay, so there's a single third ventricle. This then projects down into the fourth ventricle, which is right here. And that connection between the third and fourth ventricle is called the cerebral aqueduct. Okay, and the midbrain, if you can just kind of imagine, is right around the cerebral aqueduct to kind of give you an idea where we're at here. And then there are outlet chambers from the fourth ventricle, and from there the cerebral spinal fluid gets out into the subarachnoid space that coats the entire brain and spinal cord. Okay, so just another picture here of the lateral ventricles. Here's the interventricular foramen of Monro down to the third ventricle, then via the cerebral aqueduct to the fourth ventricle. And then we have outlet chambers here, which I mentioned. So there are two lateral outlet chambers called the foramen of Luschka. Okay, and then there is a midline outlet chamber called the foramen of Magendie. And so from these outlet chambers here, cerebral spinal fluid gets out into this subarachnoid space, which coats the entire brain. And actually, if you just want to draw down here, the lumbar cistern is down here. Remember, that's a focal enlargement of the subarachnoid space. And here we see the subarachnoid space covering the entire brain. So remember, that's between the pia and the arachnoid. Now, cerebral spinal fluid is produced by choroid plexus that is in the lateral ventricles, mainly. And so if we want to start the origin of cerebral spinal fluid, it's going to be produced here in choroid plexus, which I hope you saw in the lab. Okay, it goes into the lateral ventricle here, which is in this dotted structure here. Let's just follow the path. And it goes from there through the interventricular foramen of Monro right here, into the third ventricle, down through the cerebral aqueduct, into the fourth ventricle. Okay, and then we get through these outlet chambers, and it goes then into the subarachnoid space, which coats the spinal cord. And here we can just follow it all the way around. It coats the brain. And then finally it gets out through these arachnoid villi, which together make up an arachnoid granulation, where the cerebral spinal fluid gets out from the subarachnoid space into the venous system. Okay, so we'll talk about the venous system here in just a little bit, but here the cerebral spinal fluid then drains all the way down, and it eventually ends up going out through the internal jugular vein. So this is a very efficient system. It turns out that the hydrostatic pressure here in the cerebral spinal fluid is just slightly greater than the pressure in the venous system, and so there's continual flow of CSF from the arachnoid granulations to the subarachnoid space, and then out here into the venous sinus and out through the internal jugular vein. Okay, so almost, I think all of these drawings were done by medical students here over the years. So here's just another representation, nice drawing here of the same thing following the flow of cerebral spinal fluid. Okay, so remember from the fourth ventricle, you have the two lateral foramen of Luschka and then a single midline foramen of Magende. And this is again how the cerebrospinal fluid gets from the ventricular system into the subarachnoid space. Okay, so maybe let's look at this one. Here's the subarachnoid space, and here we see an arachnoid villus. Okay, and again, this is how the CSF gets out into the venous system, and it's mainly into the superior sagittal sinus. So what is in the CSF? Well, maybe more importantly to say what is not in the cerebrospinal fluid. Normally there are no red blood cells or white blood cells. So that's very important. When you do a lumbar puncture, if you're finding red blood cells or white blood cells, that needs to be explained somehow. The other important thing is that glucose in cerebrospinal fluid is only 2/3 that of blood. And whenever we do a lumbar puncture, very important, you always have to check the glucose in blood at the same time. Okay, extremely important because the glucose measurement is just critical as we try to figure out, does the patient have a bacterial meningitis? Do they have a viral meningitis? Glucose is about the fastest thing that comes back that gives us a clue about which of those we're dealing with. And also protein in the cerebrospinal fluid is very low, a small fraction compared to protein in the blood. And these are all things that we measure when we do a lumbar puncture. So normally what the cerebrospinal fluid does, it just cushions. The brain literally floats in the cerebrospinal fluid. Okay, and so also filters out toxic substances. And this is fairly new, and so I won't say much about this, but the lymphatic system here, a perivascular pathway where toxins from the brain, like amyloid beta, which accumulates in Alzheimer's disease. And so it's very important that this can be filtered out, and it appears that that happens through the lymphatic system. A medical student did some research with me on this, wrote a nice paper, and even did a nice drawing trying to show this perivascular space here of the lymphatic system and how this works. I won't ask you any questions about this, and this is too new for boards, but it looks like clinically quite relevant that we understand more about this. Now let's talk about some things that can go wrong with this flow of cerebrospinal fluid. One thing that's, I think, fairly obvious when you think about it, all of the CSF in the ventricular and the subarachnoid space only makes up 150 milliliters. That's not very much, but the choroid plexus makes about 500 a day. So what does that tell you? This has to circulate efficiently, or else there are going to be problems. And so if it doesn't circulate, if something happens, there's a blockage, then we can get a hydrocephalus. And there are 3 types of hydrocephalus. 2 are really true hydrocephalus. This is kind of a pseudo hydrocephalus. So let's explain here what we're talking about. So a non-communicating hydrocephalus is simply where cerebrospinal fluid does not communicate within the ventricular system. So let's say we have a blockage in the cerebral aqueduct. Well, now you no longer have a communication between the third ventricle and the fourth ventricle. Okay, so what's going to happen? Well, all that cerebrospinal fluid that's being produced in the lateral ventricles, it can't get out, and so the lateral ventricles and the third ventricle will dilate. Okay, that's a non-communicating hydrocephalus. So here, for example, we have a mass here around the third ventricle. And so the third ventricle can't communicate with the fourth ventricle, so the lateral ventricles dilate. So this is a non-communicating hydrocephalus. Okay, so again, like a cerebral aqueduct compression right here, or this lesion involves the third ventricle and the cerebral aqueduct. So the lesion is here, so these lateral ventricles just blow up. So very, very important, because these patients come in, they're often confused, and we frequently do a lumbar puncture in this situation, in the setting of a confused patient in the emergency room. But that absolutely must be avoided if we're dealing with a non-communicating hydrocephalus. And the reason is, let's imagine here the lumbar cisterna is down here, and so you decide, okay, in this patient, let's do a lumbar puncture. And so we draw a bunch of spinal fluid out of the lumbar cistern. Well, what are you doing? You're creating even more of a pressure gradient between the lateral ventricles and third ventricle and everything distal to that. And so creating more of a pressure gradient by doing a lumbar puncture, the entire contents of the brain can herniate in that situation. So as a rule of thumb, we almost always do a brain scan before we do a lumbar puncture to make sure we're not dealing with something like this, that we could end up killing the patient by doing a lumbar puncture. That's very important. Now, here we just have big ventricles. So we have hydrocephalus, but you don't know just from this single section what it is. But I did just want to explain what a communicating hydrocephalus is. A communicating hydrocephalus is where the lateral ventricles, third ventricle, fourth ventricle, there's communication. Okay, there's no blockage between the ventricular system. So the problem here is usually with the outlet chambers here, like in the arachnoid granulation. So this can happen if someone had an old meningitis or a subarachnoid hemorrhage, where you can get scarring of the arachnoid granulations so that the cerebrospinal fluid is not able to exit normally into the venous system. Okay, so in this case, we'll get enlargement of the lateral ventricles, third ventricle, fourth ventricle, and actually you can do a lumbar puncture in this situation. You don't create the dramatic pressure gradient like you have in a non-communicating hydrocephalus. All right, so here let's just say our normal ventricles. Let's just say this is how the lateral ventricles appear normally. Here they're enlarged. So this is hydrocephalus. So this could be either communicating or non-communicating. From this single drawing, you wouldn't know. And this is the other condition called a hydrocephalus ex vacuo. And so what is this? Well, notice that the brain has shrunken here. It's smaller. And this is because there's atrophy of the brain. So this is what you might see in like Alzheimer's dementia. Okay? The ventricles are bigger than the normal, but they're only bigger because there's just shrinkage of the entire brain. So they appear larger, but they're not under pressure. Okay? So we see this all the time when we do a brain scan in the elderly. The ventricles are a bit larger, and so the question is often asked, well, could this represent hydrocephalus? Well, if you're seeing lots of atrophy, no, it's not a true hydrocephalus. It's hydrocephalus ex vacuo. These are not under increased pressure like they are here. Notice out here, there's no brain atrophy. Okay, so this is a true hydrocephalus. Okay, in an autopsy, yes, these ventricles are very large, but just look at all of the atrophy. Here are the temporal lobes and the rest of the brain. Right, the third ventricle is big also, but that's just because there's less brain tissue. So this is hydrocephalus ex vacuo. Okay, a few other important points. One is about the blood-brain barrier, which we will talk about several times throughout the course. There are three components of a blood-brain barrier. First, helpful to just contrast here with any old capillary in the body, very leaky, porous. The blood-brain barrier is highly protective. And so I had the student put a lock right here to highlight that the inner endothelial cells with these tight junctions is the most important part of the blood-brain barrier. Okay, outside that, there's a basement membrane, and then there are these astrocytic foot processes from the astrocytes, which are important, but if you had to say which is the most important, it's the endothelial cells with these tight junctions. So this will be very relevant when we talk about medications. We want to know what medications can cross the blood-brain barrier. We'll also talk about conditions that can damage, it can make a leaky blood-brain barrier. So things like brain tumors, multiple sclerosis. And when we talk about giving contrast with either a CT or an MRI scan of the brain, the reason we give contrast is that in abnormal situations that disrupt the blood-brain barrier, like a tumor or multiple sclerosis, that contrast leaks into the brain. And so this can be a very helpful finding to help us diagnose certain conditions. Okay, so you can see there are some things that can cross the blood-brain barrier very easily, and some require active transport. And we'll come back to this when we get into our neuropharmacology lectures. Now, there are some areas of the brain that lack a blood-brain barrier, and these are called circumventricular organs. And I will only mention one for now, and that is this area right here called the area postrema. Right? So here's the fourth ventricle right here, so it's kind of in the lower part of the fourth ventricle. And this is otherwise known as the vomiting center of the brain. So when medications, for example, cause severe nausea and vomiting, it's because they can access the area postrema. So a lot of cancer medications will do that. We'll also talk about a unique condition in neurology called neuromyelitis optica. And these patients frequently have intractable nausea and vomiting from involvement of the area postrema. All right, finally, let's just talk a little bit about meningitis and encephalitis. I've already mentioned meningitis, where you have inflammatory cells in the subarachnoid space. So these patients present with headache, and because it's an infectious process, there's fever, and remember a lot of neck stiffness, especially if the patient's asked to bend their chin down to their chest. Okay, and so meningitis can be bacterial, viral, or fungal. And it's critically important, especially if we're dealing with bacterial fungal, that we make that diagnosis right away and get the patient on the appropriate antibiotic. Okay, what's the difference with an encephalitis? Well, if we use the term encephalitis, we mean this is not just an infection of the coverings of the brain itself is inflamed. Okay, so this is more serious generally. So a lot of overlap in symptoms. These patients also have headache and fever. But now, since the brain is involved, virtually anything can happen. If the brain is inflamed, often patients will have seizures. The patient's much more likely to be very confused, even in a coma. If the language areas of the brain are inflamed, they may have an aphasia and have difficulty speaking. Or if, let's just say, the motor cortex of the brain is involved, they may have focal weakness. So these kinds of findings here tell us, okay, the patient has headache and fever, but this is more than a meningitis. This is an encephalitis. And so these can be infectious, and I probably should have put a little more in your handout about this. We'll talk about later, but in recent years, an autoimmune encephalitis has become much, much more common and something that we need to be aware of. I will not ask you this, but it's so high yield for boards that I'm just putting it in here. In our microbiology lectures later on, they have a whole extensive section on meningitis and encephalitis, but we're trying to do some planned redundancy here. So if you want to practice learning these now, it will pay off. You need to know for boards and just practically for seeing patients, meningitis organisms by age and when they are most likely to occur. What I would like to talk about in just a little kind of introductory here is herpes simplex encephalitis, just because this is one that is quite treatable. You want to be really primed for this condition. So patients present with headache and fever, and it's an encephalitis, right? So seizures almost always occur, partly because the temporal lobes are most often involved in herpes simplex encephalitis. And the temporal lobes are the most epileptic part of the brain. Temporal lobes are also very important for mood. And so there are often personality changes. It can be quite dramatic. These patients are confused. Remember, the term for that is encephalopathy. And important language areas are in the temporal lobe. So these patients may have aphasia. So in this presentation, so I mentioned we usually image the brain first, okay? And so usually we see swelling or edema in the temporal lobe, often both temporal lobes, okay? And then we'll talk about findings on cerebral spinal fluid testing if you do a lumbar puncture. And the importance here is you want to make a rapid diagnosis and treat these patients. In fact, if we suspect herpes simplex encephalitis, we will just start treating them with the appropriate antibiotic even while we're doing the testing, because death, is high unless patients are treated quickly. Okay, so here we have a patient. We're looking at the temporal lobe here, and obviously we can see a lot of swelling here. There actually is a little bit right here on this side also. Okay, so the bilateral temporal lobe edema is quite suggestive of herpes simplex encephalitis. Now I'd like you to have a big picture when we do a lumbar puncture for meningitis encephalitis. What are we looking for? Well, you can notice that the white blood cells are elevated in bacterial, viral, fungal meningitis, herpes simplex encephalitis, and even in a subarachnoid hemorrhage. But this is just blood going into the subarachnoid space, and so the white blood cells are just proportional to what you have in arterial blood. Okay, so this is maybe not super helpful, except that in a bacterial meningitis it tends to be very elevated. Red blood cells in our bacterial, viral, and fungal meningitis are not elevated. Okay, in herpes simplex, because herpes simplex tends to be quite destructive to blood vessels in that inflammatory process, we often can get some red blood cells. And in a subarachnoid hemorrhage, where we're just having blood pour into the subarachnoid space, not surprisingly, you get a lot of red blood cells. Now, glucose, please highlight this. This is, when you do a lumbar puncture, you get some things back quickly. These are the things you get back quickly: the white blood cells, red blood cells, glucose, and protein. But really, the one that is most helpful early on is the glucose. Because if someone comes in with a headache and fever and you do a lumbar puncture, most of the time that's going to be a viral meningitis. Okay, and we're very reassured when we do a lumbar puncture and we see that the glucose is normal. Take a big sigh of relief. Oh, good. We'll give the patient fluids, we'll treat them for nausea, we'll treat their headache, and they're going to recover. But if we're getting initial findings back from the cerebral spinal fluid and we're seeing a low glucose, now we know, okay, this is very serious. We need to be on the ball and get this patient treated right away for either a bacterial meningitis or a fungal meningitis. Both of these cause a very low glucose. Okay, so never do a lumbar puncture without ordering glucose. It's extremely important. You can see a somewhat low glucose in some patients with subarachnoid hemorrhage and herpes simplex encephalitis. This is from a distortion of glucose active transport into the CSF. Protein, you can see, not that helpful. It goes up in everything. Yeah, it goes up a little more in bacterial and fungal meningitis, but that's not that helpful. The glucose here, again, in fungal and bacterial meningitis, very, very suggestive. Okay, and then we can do other testing. We can culture for the bacteria or the specific fungal organism. We can do what's called PCR testing if we want to check for like a certain virus, like a herpes simplex. And then finally, xanthochromia is something that's quite helpful because it often happens when you do a lumbar puncture, you nick a blood vessel along the way, and so you get some red blood cells. Let's just say it's a normal patient. You get some red blood cells. Well, how do you know? Are we dealing with subarachnoid hemorrhage, or did I just nick a blood vessel? We call that a traumatic tap. And so what you can do here is you ask the lab to check for xanthochromia. And so when you order that, what the lab does is they spin down the cerebral spinal fluid. Okay, and if the blood has been there for a while, like in a subarachnoid hemorrhage, the patient comes into the emergency room, hours later they get a lumbar puncture, what happens is blood that's been in the cerebral spinal fluid for a while, some of the red blood cells rupture, they release bilirubin, and we detect xanthochromia. So positive xanthochromia would suggest, okay, this is actually more serious. Your patient probably has a subarachnoid hemorrhage. If you're seeing red blood cells but xanthochromia is negative, okay, then that means it's just a traumatic tap. You nicked a blood vessel when you were doing the lumbar puncture. Okay, so again, check for xanthochromia. The other thing we'll do is when we do a lumbar puncture, we usually fill up at least 3 tubes with cerebral spinal fluid. And so if you did a traumatic tap, you're going to tend to find a lot of red blood cells in the first tube, but by the time you get to the third tube, there aren't very many more red blood cells. That's another way you can distinguish traumatic tap from subarachnoid hemorrhage.